Welcome to The Treatment Plan, a podcast about how healthcare really works, from weight loss and patient care to the systems and incentives behind it all. Hosted by Jack Usher and David Usher, MD. Okay, so I had to talk about this because employer healthcare, it affects basically everybody who's ever had a job. There's a huge focus on this right now. Ever since that, you remember that shooting that happened with Luigi?
With the United Healthcare guy.
Yeah, the CEO.
Yeah,
it
right?
seems like ever since then, there's been just like an undercurrent of this conversation online and amongst people, because it was just, the response to that was so crazy.
Yeah, like the people who were going, yeah, he deserved it, man. That group?
Yeah.
Oh, crazy.
Like totally crazy. It just, I thought it like completely exposed the anger and just like how crazy people have gotten over this, basically this issue, which is why healthcare is terrible.
Yeah, it's like it just completely exposed nerve root, like
yes.
in a dental visit. You just, really, it's a terrible thing.
The main story. So I'll lay out the story, which is, according to my research, 154 million Americans rely on employer-sponsored health insurance. So roughly half the country. In 2024, average premiums were $9,000 for a single person and $26,000 for a family.
Annual,
right. And rising costs squeeze wages and business margins. So I think the question is, how does the employer act in this particular context? What is like the process of an employer picking a healthcare plan? Who deals with it in an organization? And you can speak to any level, any size of an organization, be small, medium, large. Is there some sort of function where they are responsible? Like I said, some of them are mini insurers, some of them are responsible if they're like self-funded, for example, which we can talk about. But what's the interplay between the employer and the health insurance company? And then of course the employee, who's the patient.
Well, there's like half the country, half of the population, almost half, is covered by Medicare and Medicaid. The other half is through some sort of private insurance, if they have insurance at all. And since the Affordable Care Act passed in 2010, the deal is that if you buy health insurance from an insurance company, think BUCAs, Blue Cross, United, Cigna, and so on, Anthem, those insurance plans have to meet certain requirements with regard to covering preventive health care and the things that they will cover. And they can have up to a certain amount of what they call deductible, and a little more than that would be your maximum out-of-pocket expense that an individual or family could spend in a given plan year. The years start on a calendar date. So your health insurance plan might start on January 1 and run to December 31st. So if you're that poor, unfortunate soul that, runs into a big health problem in December and runs up your deductible, spends all your money, all the money sitting in your checking account or your HSA, or, thousands and thousands of dollars, $7,000 or $8,000, whatever your deductible is, or $3,000, depends on what your plan is. And then you flip over on December 31st. Now you've got another $7,000 you got to spend before your insurance will kick in and pay anything, right? I mean, that by itself is almost it's almost criminal neglect that they let that occur. But it is what it is. So it's the way the system works. Okay, so employers who have a minimum size, like once you hit 50, I think, full-time equivalents, employers under Obamacare have been basically forced to purchase health insurance that's affordable to their employees or pay a big tax. And so generally employers are wanting to do kind of the right thing and help their people and do right by their folks and so on. So they try to get some sort of health insurance plan going, and there's a spectrum of that. You call it either fully insured, which is calling up your local Blue Cross, Blue Cross.
Wait. So before you go into that, just say the different options that they have, and then we can break down each one.
Right. All right. So there's a spectrum of things. There's fully insured, And then there's, on the other end of the spectrum, there's fully self-insured, which is not many companies. Those are really big companies. Walmart's, for example, might be. I don't know if they are, but that's the kind of company you're talking about, that they carry all the risk. They don't buy reinsurance or anything. They just carry all the risk because they've got so much capital, so much money in the bank. And then in between those two, fully insured and self-insured, is a spectrum of things. So there's fully insured, there's partially self-funded, there's actually before that, there's a thing called level funding, and then there's partially self-insured and then fully self-insured. Those are the four ways I would think about it. A self-funded health plan has to provide the same kind of basic structure as a fully funded plan: free preventive care, for example, what they call routine care. And then the structure can be the same. You can have a high deductible health plan with an HSA, or you can have some other approach. And generally, if you do a fully funded plan, like you go to the big insurance company and say, I need to buy a policy that covers my 50 employees and their spouses and dependents. Maybe there's 100 people on the plan, and the insurance company works up a policy for you and says, here's what we'll charge. And you take it or leave it, or you make tweaks and try to get things just right. But once you agree to that and they write the contract and you say that's what we're buying, then you're on the hook for paying those premiums. And at the end of the year, just like paying your electrical bill, the money's all gone. At the end of the year, the money's all gone. You don't get any of it back. There's no way for you to conserve any of that cash on a fully funded plan because the insurance company really takes all the risk. Now, at the end of that year, whatever you ran up as charges, this year's charges becomes next year's premiums. So if you have a really big, high spending group, that maybe you have a couple breast cancer cases or a big heart attack, or somebody needs a heart transplant or some crazy expensive thing, then whatever that cost was is going to get rolled into your premiums for next year. So with a relatively small group, you might wind up with like a 30 or 40 or 75% premium increase. So instead of the company paying $1 million for their health insurance policy, next year they're going to have to pay 1.5 or 1.7 million dollars. I mean, huge increases. A self-funded plan, on the other hand, because they're self-insured, they have a different model. The employer takes some risk, but they also have some potential, if they manage their plan well, to not spend all of that money. But they have to do a little work to create a plan that will, and it might involve what we call a narrow network. You might have certain tiers and incentivize people to use a certain primary care, like a direct primary care practice, for their primary needs, and then their secondary needs, if they need to be referred out, there might be some network for that. And then they would have, like the insurance company, there are mirrored aspects to this. So the insurance companies have their pharmacy benefits manager, or PBM, and a self-funded plan will put some sort of pharmacy benefits program in place as well. Self-funded plans, if they're well designed, tend not to use the insurance company's PBMs. For example, it would make no sense, in my opinion, to use, Caremark, for example, which is owned by CVS, which is owned by some other insurance company, I can't remember which, as your PBM, because now you're paying the insurance company again, and the PBM and the way they operate. So the three biggest PBMs are owned by the three biggest insurance companies. They're all tied together in this vertically integrated, swampy kind of situation where they'll get you coming or going. If they don't increase your premiums, that's okay, because they're going to make a fortune off their PBM.
So to bring it back to like a concrete example. So this is like employer sympathy exercise. You could use your own situation as an example, because you have a good sense of the employer position. So what type of decisions are you forced to make with the options that you have now? Like what are the biggest things that you think about, and the risks that you are comfortable with taking when you're, say you're at 50 employees, you might be close to that or near that, but that size company, what do you think about? And then maybe contrast that to like somebody with 500 employees or 5,000.
Okay, so I'll take an example from our experience. We work with employers who do self-funded health plans. We have about 30 of them or so, ranging in size from 10 employees to 1,500. So a recent example is one, there's about 100 people on their plan, which is about the size we were talking about. And they were fully insured. And the insurance agent came back to them and said, you're going to have a 39% increase on your premiums. Well, the way the employer looks at that, for people who run their own businesses or run their own household even, have any kind of sense of what a budget is. What do you spend your most money on as an employer? It's either raw materials, things like that, or it's labor. And then the next line item in the United States of America is your health insurance plan that you're required to buy, right, by the Obama administration. So as that small employer, you can say, well, gee, we're going to take our third or second largest expense line item, and we're going to go up by 40% on that. I mean, that's a lot of money, right, relative to size of an employer. Or we're going to switch to a different program. We're going to go what we call self-funded or partially self-insured. One of the big issues when you think about doing that is if you had in that year where you had that 39 or 40% increase, the reason you got the increase was because you had some big bills, right? This year's charges or next year's premiums. So part of the consideration that employers have to think about is, are those going to be recurring costs, right? We're going to pay 40% more, but those 2 or 3 or 5 cases that drove our costs up so high, if that was a heart attack and the patient had coronary bypass surgery and now he's better, that cost is likely not going to be recurrent, right? Big trip to the OR, heart surgery, heart-lung bypass machine, rehab, all that stuff. That's a huge hit to the insurance coffers. But largely that could be a one and done kind of thing, right? As compared to the person who has pancreatic cancer. They have this set of recurring costs that are going to go on and on, or ovarian cancer or breast cancer. Those costs are kind of going to be recurring. You can predict that they're going to be an ongoing huge cost. Chemotherapy or immunologics, antibody-based treatments, things like that, wildly expensive. $100,000 a dose, and you're getting treated every 3 weeks. If you know that's going to be a recurring thing, then you have to think, well, maybe we're better off just paying the 40% increase and sticking with the current insurance and let the insurance company eat the cost on those things.
Right, because you're effectively capped at that 40% increase. It's almost
for the next 12 months.
For the next 12 months, yeah. It's the kind of the devil you know versus the devil you don't in that situation.
And then the following year, you have to do the same analysis and go, well, okay, what's next year going to look like based on what we know?
If you have a down year, do your premiums go down?
Well, in our circumstance, we have had people's premiums go down. Yes. When they institute direct primary care, we've had people, if they don't go down, they might remain flat. Like we've had fully insured companies come on board, put our direct primary care in place, and for 4 years have no premium increases. Or such small increases that they didn't have to pass any increase through to their employees. And that's more how they'll talk about it, is we didn't have to increase premiums on any of our employees. So that's a pretty small increase. If any occurred, it's pretty small.
So why does that occur? Because if aside from the direct primary care model, because I would assume you'd have up years and down years, and the premium doesn't fluctuate the same way unless there's some sort of correlative factor or that's just present in the entire population, which is people who get sick tend to get sick with recurring things, and that just drives, and that may very, very well may be true with obesity and diabetes and that sort of thing. But why is it not the case that it goes up and down? No, it's volatile in both directions.
That in insurance premiums?
Insurance premiums, yeah.
Yeah. Let's say it this way. If you really, really had a good year, you might see a premium decrease. What's more likely the case to happen, because that'd have to be a really good year. What's really more likely to happen is that your insurance company has to write you and your people rebate checks. Because for better or for worse, under Obamacare, the insurance company is capped at how much money they can make on a policy, and that's based on a percent of the total premium. So, for example,
is that medical loss ratio?
Yes, I think that would translate into that. So they are required to spend at least 80% of the premiums they collect. They have to spend on the care for the people who are covered, right? So if you have a really good year and you only spend 60% or 70, even 75%, that 5% difference, they have to rebate back to the employer. And, I don't know how that looks exactly. I don't know. I have one time gotten a rebate check from our health insurance company because we just didn't spend any. They were just making too much money on us, basically, as it comes down to. And so you get a price cap from the government, essentially an income cap on the insurance company. So, but I suppose if you have that on a recurring basis, they would adjust your premiums down, and more likely, I think they would just keep them the same. But I don't how exactly all that insurance stuff works. I really don't know on the fully insured side. The same thought process, though, goes on a self-insured employer.
Oh, but maybe before we say that, what's the breakdown between how many employers out there are fully insured versus self-insured?
The last I read, we had cracked probably the 50% of employers are now self-funded. As a percentage of population, I'm not quite sure. Somebody will have to fact check me on that. I'm not sure, but that gets you in the ballpark, kind of. Yeah, there's a lot of self-insured health plans out there.
Right. Well, yeah, 1 in 2, even if that's roughly, as long as it's in the neighborhood, that gives you a sense of how prevalent it is.
Right. Yeah, this used to be kind of a rarity, and now it's more and more becoming commonplace because people, employers, and the insurance advisors or brokers they work with are starting to figure out a little bit of the secret sauce. And there have been large organizations working on this for a long time, trying to help sort this out and get the free market back into medicine, because the market's been so influenced by government policy that it's just been really not completely free. There's still a market within what's there, but it's less free than it used to be. So when you move over to self-insured, the nice thing about a self-insured health plan is, or partially self-funded. Well, let's look at it this way. If you're going to spend $1 million and give it to the big insurance company and it's gone, you take that same $1 million and spend, let's say, 25 or 30% of it, and you buy what is actually an insurance policy, but in this case, it's reinsurance. It's your backstop, your stop loss policy. And then you take another, let's say 5% or 10%, and that's the cost of administering the program. And then you take another percentage, call it 10%, and you buy your primary care with that directly, if that's what you choose to do, which is what I'd recommend. Buy your primary care directly, contract with your primary care provider so that and if you have a good one, they'll work with you very closely to make sure they're running your playbook and doing the things that your plan calls for. And then you've got a little bit of, you get a PBM who's kind of independent and transparent, and maybe they work on a cost plus basis, so you're not getting jacked around with rebates and all that stuff.
Wait, yeah. So let's go into that a little bit, because that's something I don't really understand at all, which is the pharmacy side of things. So PBMs obviously have basically been maybe the last couple of years, it's been like the one person that everybody hates is like the PBM.
Right. The PBM. Yes.
Yeah, it's like Bernie Sanders and Mike Lee are both agreeing that PBMs
the
are the worst.
are a problem.
Yeah.
They're a problem, yeah.
Yeah, say a little bit more about, at least in this context.
So pharmacy benefit managerial companies or manager companies. As insurance has evolved, no longer do you have, like 50 years ago, there was hospital insurance. We called that Medicare, and there was, but there weren't that many medications around that people would have to pay for because we just didn't have all the meds we have now. We have tons of them. And you can get generic drugs or you can get brand name drugs. What is really remarkable in this country is drugs are incredibly expensive until they're generic, then they're incredibly cheap. Pharmacy benefit managers are no more, the big ones are no more about taking care of the patient than the insurance company is. They're shareholder owned. They are completely designed, like the insurance company, to maximally mine as much revenue out of premium purchaser as they can. So these what's happened is this vertical integration. So United Healthcare buys, I think they own Optum. I'm not sure. My apologies. I don't want to be, slandering anybody. But the point is, these big, huge insurance companies now own their PBMs, right? And then United Healthcare also employs like 70,000 physicians across the country. Okay, so now the doctor, the insurance, and the PBM, and then throw some hospitals in there probably. And you've got this big monolith of vertically integrated health system. If they're not making money off of you on your primary care visit, don't worry, because they'll make it off of you on the pharmacy, or they'll make it off of you on the specialty care, or they'll make it off of you in premiums. I mean, and there are several of these, right? What we call the BUCAs, the Blue Cross, United, Cigna, Aetna, Anthem, whatever the A stands for, huge insurance companies. And they've all gotten into this pharmacy benefit manager space. So they have insurance and they have this and so the pharmacy benefit managers came about because the ability to decide who's going to cover what drugs and why, and it becomes its own kind of insurance policy. So if somebody goes to the pharmacy and says, yeah, I want my insurance to cover this, your insurance company is kind of covering it, but it's really the pharmacy benefit manager piece that's going to determine whether that drug is covered and how much they'll pay the pharmacy for it and how much of a copay you might have to put on something or pay towards something. What's hidden in there are the pharmaceutical companies, not the PBM, but the companies that actually manufacture the drugs are wanting to sell their drugs. So they'll come in and kind of cut deals with the PBM to make their really expensive drug. This is an example. A tier 1 drug. It only costs the patient $5. So the patient pays $5 at the pharmacy counter, but then the insurance plan gets billed $900 for this drug. Maybe it's brand name and maybe it's no better than the generic thing, which it's $40 for the total prescription, all in price, $40. But they'll make that a $20 copay at the pharmacy counter, hoping that what the patient will do is I'll pay $5 for this one, and it's that brand name drug. Wow. What they don't tell the patient sitting there is that their health plan is going to get billed $900 for their $5 copay drug. Whereas if they would pay $20 out of pocket, their health plan would only get billed another $20. Do you get that?
Yeah.
And it's like, wow, and it's not transparent. And transparency is really the root of all the problems in all of this.
Yeah.
Nobody understands this. It's so complex that the average person on the street has a hard time understanding it.
To that point, the people that make these decisions in companies, in businesses, who are they typically? I mean, if you're small enough, it would just be the business owner. But even in mid or large or even enterprise size organizations, who makes those decisions, and are they, I don't have a lot of contact with these types of people. Are they read in on all of this? Do they understand these complexities, or are they overwhelmed?
Yeah, it really depends on the company and their focus. So they may have a human resources department head, right? The person who's in charge of taking care of the people and getting them the stuff they need. That may be the decision maker for some smaller companies. Like, this is just the guy who takes care of that, and nobody else has time or interest in it until it becomes such a huge financial burden. Then all of a sudden, the guy who really should be interested in it, one of those two guys or ladies, the chief financial officer, that's when we're talking to employers, that's the person we want at the table, is the CFO. HR people are, they love people. They want to help people. They want to help them. They want to train them. They want to onboard them. They want to offboard them. They want to do all these things. But they're not financially minded people necessarily. You might have a benefits analyst within your human resources department who's really sharp and savvy with this kind of thing, but you might not. So ultimately, because it's such a huge line item, the head of the company, the CEO, is really the one who's got to be read in on all of this, because these are huge decisions. And you may only save 10% on your health plan, but when your health plan's costing you $5 billion across the country, that's a lot of money at the end of the day. So smaller companies, what's happened with smaller companies is they just get they offer some sort of health insurance, and the HR person knows how to manage it. So when you talk about changing it, the HR people kind of freeze, and they want to help, but they've got so much on their plate now. They look at that and go, "Oh my God, I don't think I could." So you have to find that person really at the CFO level is kind of where most of these decisions should be made, because they are the people looking at the bottom line every day. I mean, that's their job, right? But in a lot of these companies, what happens is that line item kind of slowly builds, like the heat under the pot of water where the frog is waiting to boil, and nobody's paying too much attention to it. But what they're really doing, and they don't realize it, is they're running a business within their business, and that's the business of providing healthcare for people. You can run a bad business within your business, but eventually that bad business is going to start to pull your main core business down, and it's going to start holding it back. And even as an employer our size, we're bumping up on this 50 employees. You start looking at, oh my God, the cost of healthcare, health insurance, and having to offer it in a way that's affordable for your people. The Obamacare legislation laid out how much that can be. And I think, if I'm not mistaken, I think you have to make that judgment based on household income, not just the employee's pay scale. I mean, it's really bizarre in that regard. But in any case, that you get these people who may have no idea how to run a business. They're HR people, and they're great in their job.
But they weren't even aware that this business, there's a whole nother business that they need to run, that they're just, you don't even know, you don't even know, you don't know.
The fact that they don't recognize it as a business, it tells you that they don't have the business acumen necessary to run it.
Yeah.
Right. Because they just don't even recognize it. They just, this is our health plan for the year. If somebody's not breathing down their neck to try to somehow make it more economical, and if they don't have the purchasing power to make the decisions anyway, I mean, nobody should breathe down their neck, really. That's the CFO has got to be doing that. That's really kind of where it's got to land, because it's such a huge budget line item. If this was any other expense, purchasing things from any other industry, no CFO would let something run out of control like this. But because it's been what it is for so long, people just become kind of numb to the fact that this is just going to be really expensive, and they just kind of keep buying crap the same way, because it's not their core focus. They're busy making the widgets, or the Starlinks, or the whatever they're making. And if they're not focused on this, it can get out of control, and it really starts holding you back, because you're spending, the phrase I heard is, our health plan ate my pay raise year over year over year. People are living with really no increase in purchasing power. Actually, physician incomes have been relatively flat for years and years and years. Meanwhile, the amount of money we're spending on administrative positions, it's like 8 administrators per physician in our system, which is, that's nuts. That's completely unsustainable. So these employers then at some point, it becomes a pain for them. There's a pain point. It's like every patient who comes in to see me, they got something they're concerned about it. Something hurt somewhere, and they can no longer ignore it. And that's when they start looking at, maybe we should do something else. Maybe we should look at going self-insured. Or maybe if we're self-insured, we should start putting narrower networks on, so our patient can't go to that really expensive option over there. If they're not doing any better surgery or getting any better outcomes, why would we let them keep going over there and spending twice the money for the same thing they could get somewhere else with equally good outcomes? So you start thinking that way, and you start going, okay, so how can we put something together that our employees will still like, or they'll like even better than what we've been doing, that gets them great access. And in our case, what I would say is, you work with a primary care doctor or a primary care group who is committed to making sure your health plan works.
Yeah. It's the principal agent problem. It's when somebody is on your behalf making decisions of consequence for you. You have to make sure that their incentive is to make the best decision for you and not the best decision for them.
Right. You got to be aligned.
Got to be aligned. Yeah.
Right, it's all about alignment. So exactly. It's like you see these ads. We're a fiduciary. We only make money if you make money. I mean, it's about alignment. So if you have your primary care working for you, or the way we refer to it is, own your primary care. If you, as a self-funded health plan, don't own your primary care, if you don't have a group that's perfectly aligned with you and committed to making your plan work, then they're working for somebody else. And that's where self-funded health plans, if you don't arrange to get your primary care outside of a large system, then you can't expect that those primary care doctors within the large system are going to treat you differently or your people differently than they would everybody else. And what that amounts to is referring within the system. You don't think about the cost of things. You just kind of, I'm just a doctor in this clinic and I just refer where they tell me because it's easy to send you to a cardiologist within our system, and then they go over there and get their $20,000 workup or whatever, because that's just the way we all do it,
Yeah.
And physicians have become, I don't want to say dumb, but kind of dumb to that. Like, I just work for these big system, like we're victims, like we can't do anything different. And that's been really demoralizing, kind of see how that's gone. But in any case, you want your primary care to be working for you as a self-funded health plan. And so if you have that, then when your patient needs the big spend in healthcare, this should come as no surprise. The big spend in healthcare is not from primary care. The big spend is coming from specialty care, right? Surgeries and specialty care workups and specialty drugs, things like that.
Yeah, big, massive medical events and surgeries and, everyone, the stuff you recognize as the big stuff.
Right. If I can send somebody someplace for a colonoscopy for $2,000, exactly the same colonoscopy, effectively, as this place over here where they're charging $10,000 or who knows how much, and this $2,000 is a bundled price. We guarantee it. We won't charge you a dime more. And this other place gets away with $10,000 unless they have some other condition that pops up. Then they'll just keep racking it up because they're doing it on a fee-for-service basis. I've seen $22,000 colonoscopies, and we could have the same thing done for a couple grand somewhere where they just say we're doing a bundled price. Here it is, all in, because they do lots and lots of them, and they know how good they are at them, and they know that what their cost basis is, and they're not going to lose money on a $2,000 colonoscopy, right? Knee replacement's another one. I could do a knee replacement here for $70,000, or I can go over there, an average of $70,000, or I can go over there and they'll guarantee me a bundled price of $25,000 for my knee replacement. And they get great results, and they can prove it. They can prove it up. Weave a few of those together for a smaller self-funded health plan, and that's a ton of cash. But if your primary care isn't referring your people that direction with that in mind and knowing that this is what we need to do for this group because that's how their plan works, then you kind of just write a referral within your system and they go see your orthopedic surgeon who does the $70,000 knee replacement. The patient is, kind of numb to the fact that they got a $5,000 deductible, but they need a new knee, so they're willing to spend $5,000. But if you send them over to where it's $25,000, maybe they don't have it to pay anything out of pocket at all because the employer's smart enough to realize that they're going to save $50,000 on this knee. They'll give that $5,000 back to the patient, say, you don't have to pay anything towards this knee. And then we might pay you a couple $1,000s just for the trip. Drive an hour down the road, get a great new knee, and we'll pay for your wife to go with you and stay in the hotel, and we'll buy you a couple fancy dinners. I mean, the amount of money is just, in some cases, is just epic. It's a huge amount of cash. Your primary care has to be working for you in that regard and running your plays.
Yeah.
The plays out of your playbook is the way we call it. You give us the playbook and we'll quarterback the team.
Yeah, that's an insight that most people don't have at all about how healthcare works today, is that I shouldn't say that. Actually, funny enough, it's the other countries who have very tightly controlled or publicly serviced healthcare systems that end up recognizing that fact, because there's very strict cost control. There's very strict regulation. There's ways to do things. And so the standard process in, like France or UK or even Germany is you have to go through your GP. You can't just go to a specialist, which is, some people might say that's an American and we wouldn't like that here, but they know that if you go to your general practitioner, they are the ones they're the gatekeeper to the healthcare system. They funnel everybody in and out. And so you cannot go, there's nowhere to go until you go see them, because they might be able to handle it. They might be able to put you where you're supposed to go. Like you said, they kind of are the quarterback of the healthcare team all over the world, not just the United States.
Right. In the United States, a few years back, there was a big movement called health maintenance organizations.
HMOs,
HMOs, they still exist. But a lot of the population didn't like that because they don't like the idea that If they have a primary care doctor who doesn't think they need to see a specialist and they still think they need to see a specialist, by God, they're going to make a fuss and get themselves somehow to a specialist. And then, so it kind of pits the primary care doctor against the patient in some regards.
Mm-hmm.
So that the gatekeeper mentality is one that most primary care doctors don't want to be sitting in that role, because they're there to be advocates for the patient and try to get the patient feeling better. And if that means sending him to the specialist just for the specialist to tell him you don't need a surgery, you can get your physical therapy. Now, there are some specialists who would see that patient as a bank account to be tapped when they come through the door. But if your primary care is aligned with you as an employer in your plan, and you build a good plan with high value providers and so forth, those high value providers have proven themselves to not be doing surgery when you don't need surgery. And they've proven that if they do surgery, it's only going to cost you half of what it would cost you in the big system. So there's trade-offs. And then in the UK or anywhere else where you have government funded healthcare, they recognize the value of primary care. And the problem is, in this country, we don't recognize that value. It's not that we want to not let people have access to specialists. It's just that they so underfund primary care that there's so few of us as physicians relative to the population, right? I mean, 330 million and 100,000. I don't know what the number is, but something like that. And that space is being filled in by nurse practitioners and physician assistants, all of whom are great people, can do a great job, but they don't have the depth of experience or the confidence that the physician might have to be able to manage things without referring to a specialist.
And not even in the authority in some cases, just depending on what you need.
Yeah, right? And depending on what state you're in, right? You could be in a state where, a nurse practitioner can't prescribe drugs. I mean, really weird situations. In Wisconsin, the PAs and nurse practitioners have pretty wide latitude. But in any case, they would be more inclined to refer earlier for things because they just don't have the depth of medical training that physicians have. So you fill in that primary care space with a bunch of people who are prone to referring to specialists. Well, if you're a specialist, that's a great deal. If you're the people in charge of how things get reimbursed, which we may have talked about before, at the highest level, like CMS and the American Medical Association and so forth, and they kind of figure out who gets paid what. Well, primary care doctors get paid relatively little. But what's very interesting is, you get all of these big systems have gone around snapping up primary care practices because primary care doctors are willing to sell out because Medicare is such a headache to work with that it's just easier to work for somebody else. But then those same systems will turn around and poo-poo the primary care and say, well, you guys just lose money. You're just a funnel for specialty referrals for us. Well, yes, we lose the system money, but we are obviously very valuable. They want more of us. They keep buying up these practices, and the reason is serve as a funnel of the high-paid specialty care opportunity. So,
right, and never mind that the patient going to specialty care, it might very well be warranted, but it's not saving them any money.
Right,
go to to go see a specialist.
Exactly, and nobody within a system like that wants to give a primary care physician credit for being cost effective, right? It's just not designed. And they have there are a lot of different ways they're trying to get at this, but ACOs and value-based care, all these various things. But everybody's missing out on the key components of primary care. Has to have enough time to spend with a patient to be able to hear what they say and get at what the real problem is. Meanwhile, though, everybody wants to pay the primary care doctor in nickels and dimes. So the only way they make a reasonable living is to just see lots of patients. 26, 30 patients a day. I mean, crazy numbers.
So not only do you get a bad patient experience or a rushed patient visit with the doctor who's got 14 people before you and 15 people ahead of you, and you're just a cog in the wheel, but combine that with a primary care provider shortage across the country, and you have long wait times, you can't get access. And in the meantime, you have people who might otherwise have something that they can get dealt with by a primary care provider. If you get them seen in a couple days, a month goes by to 2 months, 6 weeks, whatever it takes, and the problem could be much more severe.
Right. Or the patient just gives up and runs into the urgent care or the ER, and then they're stuck with a $2,000 bill for their, what would have been a couple $100 in the doctor's office. Now it's 10x.
Yeah. And that's not good. And the ER and the urgent care, they don't really appreciate that either, because maybe from a financial standpoint, maybe, but just from a practical standpoint, you talk to an ER doc, they don't want somebody in there who should be, at their primary care provider. It just doesn't work for anyone.
Right. This is not an emergency. So what do? They start hiring mid-levels. They put a PA in the ER, and anything that doesn't look like an emergency, the PA sees it at a really huge cost. So you wind up with this really weird system where it just is, but it's completely slanted towards moving patients to the more expensive specialty care. And the only way to get around that is to, in my opinion, humbly, our experience is that if you start paying for primary care differently, if you're individual patient or a self-funded health plan, or a fully funded health plan, like you're buying your insurance policy this year, but next year we plan to go self-insured. But you buy your primary care differently. You contract with an independent primary care person who's aligned with you, right? Or an independent primary care group, because they're not beholden to an insurance company or a hospital or, a big health system to generate revenue for those people. You're just there to work for the employer, and the employer, in a sense, kind of becomes your patient, in the sense that you understand their pain points, you know what hurts, you're going to help them treat that by doing these things differently for them so that they get a better value for the healthcare dollar.
Yeah, it's like, I guess a lawyer is not a great example, but you have a client and your relationship is direct. And
right.
So there's no intermediary, there's no conflict of interest, because your interest is, you've agreed on what your interests are and you've laid that all out. And there's
you get disbarred if you start introducing a conflict.
Right. So there's no intermediary that's befuddling the relationship, or, like I said earlier, that principal agent problem is solved, which is, again, something I don't think people recognize about healthcare, or that people recognize, but they don't know there's an alternative way, or that this is the framework that's making this possible.
Right. That's exactly right. If you've got somebody you've got a patient and you have a doctor, and the person who's paying the doctor is not the patient, and the doctor is not even responsible for the price of the thing, right? You've got introduced like 2 levels of inefficiency, where if you pull
or misalignment,
yeah, if you cut all that out, like the doctor knows the price and the patient has to pay it, that quickly tightens up that relationship. Like, it's just like negotiating with a roofing contractor. We had a big hailstorm here recently. So, what are you going to charge for that? Well, I don't know. What's your insurance say they're going to pay? Well, can't you just write me a quote? No, can't do that until after I see the quote. It's this, you're a roofing guy. Don't you know what a roof costs? Just measure the squares on my roof and tell me what you charge me. Oh, can't do that. Got to see if the insurance is going to pay. Wow. And that's going on in healthcare all the time at every level. Thousands of little billing codes and all this, and it's a suboptimal system. It is what we got. I think we're going to get it better. But for the moment, we're kind of stuck with it. But we're not stuck with it. People allow themselves to be stuck with it. Employers but they're getting smarter. Everybody's getting smarter. As the prices keep going up, it's going to drive more and more people to just start doing some looking and reading and talking and listening to these podcasts. The solution is out there. This is not new. We've been working with some employers for 13 or 14 years, and they have just saved $1 bazillion in health spend because they've figured out high value care, primary care that is aligned with us. So we take advantage of that high value care, and our patients love it because they get more time with their doctor. And I'll just start waxing on about our primary care model, but it really is. I think it's the way forward. And books, Health Rosetta, the CEO that Saved Healthcare by Dave Chase. There's a ton of stuff out there now. It's known. The solution is out there. It's just that people haven't had enough pain. It's like, we know knee replacements can be done, but the patient whose knee doesn't hurt badly enough, they're not going to go seek a really good knee replacement. And employers who aren't in enough financial pain won't go look for a healthcare replacement until the pain gets bad enough.
There you go. There you have it.
Thanks for listening to The Treatment Plan.
If you enjoyed the conversation, subscribe on YouTube, follow on Spotify or Apple Podcasts, and turn on notifications so you never miss an episode. And if someone comes to mind who'd like this show, tell them about it or send it their way using the share button.